My father has never suffered from any knee pain or arthritis. The main reason for knee pains in younger generation.
This middle-aged knee pain can be from
Knee arthritis in our Indian population more than Western population.
knee osteoarthritis incidence is slightly.
Future of robotics in knee replacement.
See, robotics is something.
What do you think of these alternative therapies of Ayurveda, massage or homeopathy? Injections.
There is a role for injections in.
Hi everyone, welcome to the podcast episode of Wisdom Talks. Today we have a very special guest, Dr. Arun Kannan. Dr. Arun Kannan, if I tell you, I invited him because he is one of my dearest friend. That's the special reason. But apart from it, he is a very accomplished physician and surgeon. He has completed his training abroad, and more important is he has really brought the knowledge and skills from there to the developing country like us in India and serving the public. He practices in Chennai Apollo hospitals. So let's welcome him.
Hi. Thanks, Ramprasad. That is a pleasure to be here on your channel.
Yeah. How was your day? How is it going on? I think I had really pursued to do this podcast with me. Even after that hectic day of 4 or 5 surgeries, you made time to discuss.
It's always a pleasure to be on your channel, a privilege. It's a very nice channel. I've seen a lot of your videos. I've taken inspiration from that. So I'm happy to be here on this channel. Fairly usual day, evening, it has become, we've occupied with this. So I'm hoping it will be useful for everybody.
Yeah. Okay, let's go into the core topic for today. We'll discuss more about these knee pains and arthritis, and we'll bust the myths in the public about this knee pain and arthritis, because even nowadays the Google internet is also giving so much information that it is actually overshadowing the doctor's clinical experience, I feel. So what do you think the main reason for knee pains in younger generation? Because when you see the incidents, even you take my story, my father has never suffered from any knee pain or arthritis. And even now I am 42, I feel difficulty in climbing steps. This is my story. You must have heard many stories like this, that this knee pain and arthritis really starting in younger generation. What do you feel the reason behind this?
I feel this middle-aged knee pain can be from two different extremes. That is my take on it. One extreme is people who are very sedentary, overweight, have not exercised their knee much, and therefore start to develop knee pain in middle ages and early 40s and 50. That kind of knee pain is there. And there is also the second category that we cannot, ignore today. Fitness has become very popular nowadays. So there are people who do a lot of things for fitness. I think some of them do test their ability fair amount, and they test their knee.
So you mean to say that they are taking too much to the limits?
Too much to the limits,
their bodies.
Yeah. So there are both kinds of categories. One is the sedentary lifestyle, overweight people developing knee pain. On the other extreme, we have the extremely active people doing squats and lunges in an extreme manner.
And playing extreme sports.
Getting minor injuries and accumulating injuries and overuse injuries. And I think you should be able to relate to that now. So there are both categories. There are both ways. I think everything in moderation works probably the best, but again, it's a life choice. If you want to be active, I'm not going to say you should not be active, but that is also there is also a flip side to that. Yeah. Another
big reason I find in this middle-aged people is this clinical pathology of chondromalacia. Everyone has a very big question that chondromalacia means the degenerative changes behind the patella. Is it a precursor? That means in future it's going to develop into osteoarthritis. Is there any relation like that, or what do you feel?
See, chondromalacia affecting middle-aged people, a lot of them go away. I tell my patients that this is not something that you should be worried that it is going to be permanent.
Yeah.
So if chondromalacia is there and there are no X-ray changes, and you kind of improve your exercise stamina, do regular knee exercises, bring your weight under control, and do activities that are not extremely stressful on the knee, a lot of them go away with time.
So you mean
So
to
they
say
might
this
develop osteoarthritis later on, but I don't think the chondromalacia itself continues as osteoarthritis in many cases. In many cases, it improves. People are good. They have pain at 35. It disappears in 1 or 2 years, and then they are good till they are about 50, 55. Maybe after that, it is age-related arthritis that might set in, not necessarily related to the chondromalacia that they are having.
Yeah. Another important question, is the incidence of knee arthritis in our Indian population more than Western population? And if so, what do you think is the reason behind it?
I feel knee osteoarthritis incidence is slightly higher and slightly earlier onset than in Western population that I have seen.
Okay.
I was there for 2 years in the US and 6 months in Australia. So there the knee osteoarthritis patients were slightly of a slightly older age group is what I felt, and that is similar to what we see with somewhat with diabetes also. That's what our endocrinology people say, that they are seeing early onset diabetes, early onset metabolic syndromes than the West. Maybe it is something that we have to ponder. I have seen younger people in 35s and 40 with knee arthritis developing, and that is something that we are beginning to see. The reason I think is the way our knees are built. I think we have a slightly more population that has more bow legs than the West.
Yeah.
So that might be one factor that predisposes. But at the same time, we all know that hip osteoarthritis is rarer in our population than the Western population. So maybe they cancel out each other over the long term. But knee osteoarthritis per se, I would think is slightly more in our population than in the West.
So because we are basically an agrarian community, and most of 70 to 80% of the population still do hard work and do all this labor work and everything, carrying heavy weights, and our practices of, I think, squatting and everything adds up, and I think genetics also should play a role. So as you said, I think compared to the Western population, our incidence of knee arthritis, I think it might be something 10 years earlier.
Yeah, I think 5 to 10 years earlier is what I would think, yeah.
So if you have a knee arthritis patient coming to you, okay, it's not really grade 4 and it's not surgical. Let's not discuss that category as of now. If you have a grade 2 or grade 3 moderate arthritis, what do you suggest him? This is the single most effective treatment modality, may it be medicines, lifestyle, or whatever it is. So yeah, this will cut down your pain and slow down the pace of arthritis.
So in my opinion, if patient has mild to moderate osteoarthritis and if they are overweight, then my first or most important instruction is weight reduction is probably the number one factor that will reduce their pain as well as increase the longevity of their knee.
Yeah.
So that is what I tell my patients. Patients who are not overweight, so that will be another category. So then we look at what other factors is contributing to an early onset arthritis.
Okay.
Whether it is bow-legged, whether it is their activities, and then modify accordingly. But I think body weight is the number one factor in my mind most of the time, and I think 80% of them with knee osteoarthritis have some degree of higher weight than they should ideally be carrying.
Yeah. As you said, this is the single most effective treatment modality. Because literature evidence also supports that, 50%, if you just reduce your weight by 5 to 10 kilos, almost 50% of your knee pain can go. Yeah, and it really increases the longevity of their knee. And another thing I want to ask you, what is this hype about this collagen and glucosamine tablets, which are really widely available in India, and people in India bring their supplements from US as well. So what do you think? Really they work, or it's just a supplemental thing? Works like a placebo?
Maybe slightly better than placebo, but it is, as you know, there is not very hard evidence or high quality evidence to say that these supplements increase either the longevity of the knee or make the knee osteoarthritis better. There is no good quality evidence to say that. There are a lot of studies that support use of collagen supplements or glucosamines for improving pain and function. They have been shown to be working better than placebo, but the quality of evidence is not very high.
Yeah.
So I think most of our orthopedic community, we all routinely prescribe these supplements. These are all basically, substances that are found in the knee joint, and as degradation go on, we are supplementing like a vitamin. It's like taking a vitamin C for a cold. I think so it helps. Somewhat, but not a very big benefit with this.
It's not like a medicine that and there is no harm in taking it.
Yes. So
unless
they are
you have
basically
specific
neutral.
Allergy or really an eccentric guy. Yeah. And I think you stay in Tamil Nadu. So I think Kerala and Tamil Nadu, there is really much more bigger belief in Ayurveda. So do you believe really in Ayurveda? Because many of the patients, I feel, they see allopathy as a branch with more adverse effects than the alternative therapies. So what do you think of these alternative therapies of Ayurveda, massage or homeopathy?
I think there is a role for physical forms of treatment for knee osteoarthritis to improve the pain and function.
Yeah, right.
Like physiotherapy is one form that we commonly prescribe. Apart from that, I think a lot of these physical modalities, physical meaning non-pharmacological, non-medicinal treatments that work and improve knee function. Like acupuncture is one. Acupuncture is shown to have good relief. Not good relief, but definitely it helps some people. Similarly, Ayurveda. If a patient comes to me and says, I want to have Ayurveda and they have mild to moderate osteoarthritis, I'm perfectly okay with that. I said, very well, you can go try that and then come back. But one thing I tell them is, there is nothing in any medicine or a specific form of massage that will increase the life of the knee or alter the course of the disease.
Yeah.
But symptomatic benefit has been shown with multiple forms of physical modalities, and I am not against it. Their massages and oil massages, I am perfectly okay with that. If it gives them good relief, let them have it. There is no problem with that. But I think there is no medicine or any massage that has been proven to increase the life of the knee or change the course of the disease.
Yeah. So you mean to say that the knee pain may come down, but the progression of arthritis and everything, it's according to the natural history.
Yeah,
right.
And I think one differentiation that I commonly would like patients to kind of imbibe is when they have other than osteoarthritis, specifically if they are rheumatoid, then I tell them to stick with allopathic medications that are definitely proven to alter the disease course. So in those cases, I tell them, no, you stick to allopathic medicines. They are known to alter and slow down the progression of disease and control it than alternative treatments. So osteoarthritis, I'm fine with them going going away from allopathy and then coming back for some time. But rheumatoid, I think they should go to a rheumatologist and get it taken care of.
Yeah. Coming specifically to dietary recommendation, do you have any specific diet plan for knee arthritis patients, or can you throw some light on it?
First thing I tell them is there is no magic food that will either make your arthritis go away or make it slow down. There is no magic medicine. There is no magic superfood for knee osteoarthritis. And I think everybody knows that by now. But there is a role for diet. We were talking about, I told you my first recommendation is always weight reduction. And weight reduction has to come through a diet. That is the number one form.
Come through diet and exercise.
So I tell them, most of my patients, we have kind of a basic diet chart we send to a patient. But apart from that, most of the time I tell them this is a generic one. For a more specific advice, I ask them, many of them I send for a dietitian advice. I send them to a dietitian let them have a dietitian see them, see what their conditions are, make a tailored diet plan. An overall diet plan, I think, will help in kind of reducing the weight and give more antioxidants.
Yeah.
So fresh fruits and vegetables.
Yeah.
And there are like all these herbs, and there are some herbal supplements that are kind of believed to help with arthritis. I'm okay with them taking all that. So my dietitian, whom I refer to, they give all those medications or all those foods that contain all these
antioxidants.
But I think it is important to stress that it is an overall diet plan and not one specific food that you can either avoid or take to improve or deteriorate arthritis.
Yeah. Another hot question among the population suffering from knee pains and arthritis is injections into the knee joint and role of regenerative medicine, because everyone feels that with this regenerative medicine some magic may happen and they can really avoid surgical intervention. Throw some light on this injections and regenerative medicinal protocols.
So in mild to moderate osteoarthritis, we are not talking about severe arthritis when the bone has fully gone. I think and that is where an important distinction has to be made. There is a role for injections in mild to moderate osteoarthritis, but in severe osteoarthritis, very little role. That is the first thing that I would like to clarify. And even in mild to moderate osteoarthritis, I think injection has to be a part of a multimodal treatment.
Yeah.
Injections alone cannot do the job for any knee arthritis.
Yeah, agree.
So in my practice, patient coming with mild to moderate osteoarthritis, I would put them on weight reduction program through diet. And if not through diet, then people who are not able to do through diet, I have now started sending them for weight reduction medications also.
Okay. So you mean to say this recently GP1 inhibitors or?
Yeah, GLP-1 agonists. Those are medicines that earlier I have been recommending it through our endocrinologist. We used to have an endocrinology consultant, and as we have gained more experience, I have been prescribing those medicines myself in patients who are already have done a diet program, not losing weight to help them. So weight reduction exercise program, changing the biomechanics with either if they are bow-legged, then change the way they walk, their activities we change. So along with all these, we can add injections is what I feel.
So maybe it may be a steroid or a PRP or a BMAC injection.
So I usually use 3 injections, steroids, PRPs and the viscosupplement or gel injections as they are popularly called by the public. So I use all 3 of them, but on
a
very
specific indication.
Yeah, so that will be very individualized what injection to go for. But again, all these will generally come in only in mild to moderate cases.
Yeah.
And generally it is not the starting treatment. I put them on exercises, weight reduction, diet, activity modifications, and then only in the next visit I'm generally talking about an injection if depending on how they do.
Yeah. So you also agree that injections have a role, but specific indications, and they are a part of multimodal treatment protocol.
Yes.
They alone cannot work, and they are not an alternative to surgery in severe form of knee arthritis.
Yes, that is something I think we have to stress. So I think in severe forms, I don't give almost 0 injections in patients with severe or bone-on-bone arthritis. So in those patients, I almost never give injections because and in those cases, only very selectively steroid injections for people who want to have, let's say, they are having a function at home, they want to get through it without pain. Those patients, 2 or 3 weeks relief, I think steroids can give. So very specific, very small portion of those patients get a steroid injection. But I think PRP or gel injections have proven that in severe arthritis, there is no role for those injections.
Because, a lot of misinformation has been in public that if it is an alternative to the surgery, we are playing with the hope and time for the patient, because it plays a huge role in getting them back to their normal activities, right? Let's come to the surgical interventions, because you also have been trained a lot in this knee replacements and robotics and sorts of knee surgeries. So what do you think? Is knee replacement for everyone, or how do you select a patient for a knee replacement surgery?
So I think slightly there is in my I have selection points. So one is they generally have to have grade 4 arthritis on X-ray.
Yeah.
That is only one part of the indication. Plus they should have significant restriction of their daily activities. As a thumb rule or a general rule, I tell most of my patients, if you are not able to walk 10 minutes, 15 minutes without pain, and you have severe arthritis on X-ray, that is the stage I would generally consider a knee replacement for you.
Yeah.
So they should, most of them fit in that criteria who wants a knee replacement. So I think X-ray has to show severe arthritis, plus they should
grade
have
3 or 4.
Yeah, mostly grade 3 maybe is about less than 10% in my cases. I think grade 4, most of them will be grade 4 plus symptoms that restrict their activities. I think grade 4 without much symptoms also we don't generally, we leave them as is. And grade 3 we try other forms of treatment, and if they still continue to have significant pain, that is when we operate.
Yeah, I think I would like to add another indication. I think depending on painkillers, analgesic dependent, that if they want really an painkiller every day, but still they are resisting to take it, or they are taking it. Because analgesic dependence is one of the biggest indications for knee arthritis, and it can really lead to disasters.
Yeah, definitely. I think our nephrologists see a good number of patients with these pain medicines causing kidney problems and stuff like that. But I mean, in general, in our place, I find most of patients, they take pain medicines on and off, but they are generally wise enough not to take it on a daily basis. They have been, I think, that way a population has been careful.
Yeah, because we see a lot of rural population, and they don't really have knowledge about these painkillers, and they buy these medicines from the local medical shop, and if you ask their history, they have been taking the same medicine for 10 years, 15 years. I will be very surprised to hear that sort of histories from them. And another thing I would like to ask, what's the real age criteria that you would advise a knee replacement for a patient?
I think a general thing to say would be 55 to 80 would be kind of the optimal age for a knee replacement. And within that, 60 to 75 is probably the sweet spot. But that doesn't mean that I wouldn't do a knee replacement in a patient who is, let's say, 45, 47 years old or 85 years old. I have done in either extremes. I think the youngest knee replacement was maybe 20 years, who had a rheumatoid arthritis and was totally bedbound. So those are extremes. But there is no strict age criteria, I would say. If you are not able to walk well 5 to 10 minutes, I think if you are 50 and have severe arthritis, I would still recommend a knee replacement. Because if you are not walking well at 50, you are stuck at home at 50, there isn't, in my mind, not much logic in preserving your knee for when you are 80.
Yeah.
Okay, so I think regular knee osteoarthritis, the lowest age I would have done a knee replacement is about 41, 42. I have done knee replacements for osteoarthritis. But again, most of the patients, I think the sweet spot would be somewhere 60 to 75.
Yeah. Another thing is, in counseling the patients, if they are in extremes, is the timeline they will be going through. Because if you are doing knee replacement in a very young patient, I think the patient should be aware of the future need of revision surgeries, and as a doctor, they believe in you. So I think they should be more aware of the timeline and the future surgeries they might need in future. Yeah, that should be the part of counseling, I feel.
Yeah, I think any patient under the age of 55 and requiring a knee replacement ought to know that they might have a second surgery in the future. We now have good data. If you do a knee replacement and on 100 people and you wait 20 years, only 8 of them would have required a revision in 20 years.
20 years.
So 92% success is 20 years is quite well known, well established from a lot of registries. 90 to 92% they do well for 20 years. And I think that is something that we can all take comfort from and also give the same confidence to our patients.
Yeah, another point I would like to ask, even after a knee replacement, I tell this patients that 90% you will have pain relief and you will be back to your normal activities. And most of the success result depends on implant, surgeon, or do you feel is any other factor that will play a role?
I think it is multifactorial. It will depend on the patient, implant, surgeon. All of them are part of the equation here. So I think it is multifactorial, and as you rightly said, it is not 100% normal knee that we are giving. On an average, a knee replacement, I tell my patients, is about 85 to 90% of what a normal knee would be. And I think we are still not at a stage as orthopedic surgeons or joint replacement surgeons to claim that we'll give a knee that was as good as your natural knee.
Yeah.
It is 10-15% less than the natural knee in most cases.
Yeah.
There are some patients who come in with the forgotten joint, but I think the norm would be to tell that it is 85 to 90% of a normal knee. That is what you would get.
Yeah. Do you suggest any best implant that this can do magic and this can last more? Is it really literature evidence suggests like that, or what do you feel?
No, I tell them I use one particular company and this is as good as the top 4 or 5 implants all have pretty much similar results in today's world. So there are 4 or 5 options currently available in India, and all of them fairly have, there are multiple options available, but I generally rely on time-tested ones that have been used in registries and have a registry record. So I think when I say, I generally tell them this is not the best, but this is not second to any other implant what I'm using for you. That is what I would tell them.
Yeah, I think as we come from good institutes like AIIMS, I think we depend more on literature evidence to support our treatments rather than what's happening or buzzing in the market, right?
Yeah.
Yeah. So another thing I would like to ask you, there is too much hype about this robotic technologies, and you have been also using this robotic assisted total knee replacement, and recently only we have also started taking your inspiration from the last 3 months. Yeah, I found it advantageous, but I would like to push more about this robotics and future of robotics in knee replacement.
See, robotics is something that I've been following for almost 4 years now. So we've been doing robotic joint replacements for 4 years now. I think I've been saying it from the start, and maybe almost the same I'm telling the patients now. It is not twice as good as a conventional knee replacement. That is not something that I'm going to tell my patients. I tell them it is going to be a more accurate or more precise way to position the implants. So as a surgeon, when we do it 100 times, even the best surgeons are known to miss it 10 to 15 times.
Oh, yeah, that's a big
that's
number.
a fair number. I think 90% would be a very good surgeon. Every time the angle we plan, if you are able to put in exactly 90% of patients, I think he is an excellent surgeon. And there are a lot of studies from really great, excellent surgeons who have assessed their own accuracy, and they have found it about 85 to 90%. Exact angle what they want to put in, did they achieve? Yeah, 85 to 90%. Yeah. So I think the robot helps us do it in a more reliable manner. I think there are a good number of robotic studies, and I would kind of put the ballpark somewhere around. Just in terms of how accurately we position implants and getting a good X-ray, robots are about close to 99% effective in that one part of that surgery.
Yeah.
So in general, I tell my patients, for each patient, I don't know, but for you to, if I use a robot, I'm less likely to commit an error that I don't want to commit in terms of those angles. So that is all the robot does for you. It helps you be more precise. And I think that's about 8 to 10% advantage in terms of if you look at 100 patients.
Yeah.
Around 8-9 patients you would have avoided an error, in the overall. You didn't want to. But whether it affects your short-term function,
long-term
blood loss and all that, but I don't think there is, I don't tell my patients, let's say there is a 10% difference between robotic and conventional. You are going to recover in 30 days versus 27 days. That is not the reason that I'm going to do the robotic for you. I'm doing the robotic to help you or to help myself, and you have a accurately positioned knee replacement. And I think it will be better for the long term if you have a well-aligned knee, well-aligned components.
Yeah, I agree.
And I think it's maybe a 10% advantage with robotics is what I commonly tell my patients.
Yeah, I also convey the same, that as it's a single time surgery in most of the patients in your life, I think if you are affordable, it is always better to use technology, because it is only going to assist the surgeon, and as of now it is not replacing us, and I don't know what is going to happen in future also.
In future, we'll have to wait and see. But I think robotics has given, I think it is an advancement as compared to what was available before.
Yeah.
And I'm hoping that it will become better in the future. Although I think we are somewhere close to as good as we can get, but I'm sure there will be some more improvements.
Yeah. Another thing I would like to ask is, there are many other alternative surgical options also. Let's say partial knee replacement, because compared to the Western world, I think in the last 5 to 10 years, this partial knee replacement is picking up more in India as well. So what do you think, where does this partial knee replacement really fit in Indian patients?
I used to train with the surgeon who did almost 60% of his knee replacements were partial knee replacement, and that's a very high number, I know.
Yeah.
But he had that kind of a practice, so I had the opportunity to see a lot of these partial knee replacements. And even before robotics came in, I was very much into partial knee replacements, did a lot of them. But I think in our scenario, in our population with bow legs, there is only a small percentage of patients who are good for a partial knee replacement.
Okay.
In my practice, about 5% up to 10% a year is partial knee replacement. I think still more than 90% of knee replacements I do are total knee replacements. Partial knee replacement helps them. It's a less invasive surgery, gives a more natural feel to the knee, I feel. And the thing is, if I may, I generally give them both options, keep both the options available on table also. If there is any damage in any other part of the knee, I go ahead and convert or straight away proceed with the total knee replacement. But the results of total knee replacement have also improved quite considerably, and I think that has kind of lessened the gap between a partial knee and a total knee in terms of function. Yeah, I think partial knee is a good option, but patient
if you
selection.
Have isolated medial compartment arthritis.
Yeah.
And
if only one portion of the knee is damaged, I have no problem, partial knee replacement. But if there is anything more, then I would not have a low threshold
for conversion to a total knee.
Yes.
Yeah. So you keep both the options open in almost every case.
Yes.
Yeah. Prior to and counseling with the patient in the preoperative period, right?
Yeah.
And another thing is, do you really do this high tibial osteotomies or distal femoral osteotomies, preservation of the knee? So, because many of the patients, they ask, they want their natural knee to be there, and maybe the rural population, I think this question will be mostly posed to us, because they will be doing this agricultural works and lifting heavy weights or sitting on the floor. So what's your take on this osteotomies around knee joint?
I think osteotomies are good. Again, like partial knee replacement, the patient, we have to properly select the patients who would benefit from a high tibial osteotomy. My general criterion would be patients less than 55 years old and not having bone-on-bone arthritis.
Yeah.
So those are patients that I
grade
select.
4 restrict, no.
Grade 4, I don't do osteotomies. And more than 55 years of age, I generally don't do osteotomies.
So,
So I have both these criteria. So within that, if they are less than 55 years with less than bone-on-bone arthritis, if they are having difficulty with walking more than 15 minutes, those are
and
the
they have a significant
bow leg.
varus, bow leg and everything, and you feel that this alignment change can really decelerate the progression of arthritis.
Yeah, so those are patients I offer knee replacement. I generally high tibial osteotomy, and I tell them generally it will last somewhere around 10 to 12 years.
10 to 12 years. Yeah, I think to summarize the healthy discussion we had, that there is no really single most effective measure that this will work in preventing or treating knee arthritis. It is all part and parcel of a multimodal treatment protocol. And you mean to say that dietary modifications along with exercise and weight reduction play a major role in mild to moderate arthritis. And in severe arthritis, as everyone agrees that knee replacement procedures are really a game changer in the last 20 to 30 years, as we have seen results in many patients. And the results of knee replacement depends on implant, surgeon and patient expectation and how close he is to the reality. I think they should be realistic about the new equilibrium set for that patient. They should be prepared for the new equilibrium status. Yeah.
Yeah, exactly. I think I would totally agree with that. Yeah, knee replacement is a good procedure, gives good relief for a long period of time, but it's not as good as a natural knee, slightly less, 85-90% of a normal knee.
Yeah. So thank you for your valuable time, Arun. Thank you for joining us.
Thank you. It was a pleasure being here.
Thank you.